helping a company develop a new CAR T product. You know, that's sort of new research. I got a couple of projects to come along the way. You know, and then I've learned some stuff to, you know, we're able to share. So, yeah, so to all of you, I mean, I think this is our, we've been doing, this is going to start our third year now, coming up in February, I think is when, or late January, early February will be our third year. I think I've understand that part of what the goal is, you know, not, as I was pointed out, not everyone's on the call. Everyone's got other, a lot of people have to be in different places, but it is used as CME. I understand. I'm going to work really hard to make sure that I provide educational opportunities. I look forward to what we can do going forth. I did, and we ended up talking with your team about potential projects that we could do, and I think we'll talk about that on January 24th. You know, I think that there's interest and excitement, and you know, it's obviously, you know, you can only do little steps at a time, but hopefully little steps build up, and you know, everyone gets better because of it.
Good. Okay. Yeah.
So, and then Justin is here with us. Justin is always very reliable.
It's nice to hear all this from the side. I'm just grateful to you for your hosting, and I'm also grateful for Thailand for being such good visitors.
Yeah. And I will also, I don't, you know, over here, it's like we're 3 days away from what often our big holidays. We have the Christmas holiday, and then the New Year's takes over very soon. And so a lot of the hospital is like shutting down, but I'm just going to be working, covering the inpatient service for about 10 days. So everyone else can have the holiday.
I'm very sorry, Richard. You're a good man.
I like doing that stuff. I learn from it. So I don't know if you want, I can just, you know, take the 30 minutes or 35 minutes to share some thoughts. And hopefully you see that.
Oh my God, it's a miracle, Richard. It's a miracle.
I know. It's like it actually
it's a Christmas
worked.
miracle.
It worked.
Yeah,
I
you
think
can
today.
do it. You can do it.
So this is like got to be the first time, but we'll see. You know, it actually worked today. Who knows? Probably not next month. But anyways, what I did is every year in the end of January, I give a review of updates in transplant and updates in CAR T. And there's so much going on. I just thought this one here is, I'm still going to generate an overall package of what's updates, but I want to show you what I thought was my updates, you know, my highlights of ASH. What did I learn? And so I said the agendas, we're going to talk about this. And part of my agenda here was just to remind us that, you know, I was going to bring up talking about the visitors, the 8 team members, and what we should do for follow-up. We've got that covered on January 24th. We'll have a session totally devoted to the visit from the BDMS teams to OHSU, and I'll look forward to that. So the session today, though, is there's a lot of information, a lot of data, but it's also very short because, as I said, there's like 9,000 abstracts, somewhere in that range. There's so many simultaneous presentations. So I just picked what are some highlights of disease that's important for us to know about, some highlights about transplantation, some highlights on cell therapy. And so that's where I was going to talk. So first on disease. Well, first and foremost, the world in the United States, the world is like the headlines everywhere is sickle cell. The day before or right during ASH, the first day of the ASH meeting is often industry sponsored, and then the official meeting is on Saturday. Well, on the Friday, which is the day before ASH starts, which is Industry Day, the FDA in the United States announced that they are providing a FDA approval for two gene therapies now for sickle cell anemia. So beta thalassemia, which is not a health hazard in the United States, it's a bigger problem in countries. You have a bigger problem with thalassemia than we do. Italy and the Mediterranean countries. But the beta thalassemia was approved last year. But sickle cell is a major problem because of the large African American population across the United States. And so this is a first presentation. I pulled this out from the past. This is from 2020 when Mark Walters from San Francisco presented the first few patients treated, the first 6 patients treated with lentiglobin, which is a bluebird product for sickle cell. And they did it into, now this is a myeloablative induction regimen. It's autologous. They purified the autologous CD34 cells by giving plerixafor without growth factor. Growth factors can stimulate a sickle crisis. So they gave a single infusion or single injection of plerixafor, and they collected, peripheral blood stem cells. Some of them needed 2 collections, but they then saved those cells and cryopreserved them. And what you could see is, if you just look at the top figure is, hemoglobin S is in green, and hemoglobin A is the genetically modified and gene corrected sickle cell. They turning it from hemoglobin S to hemoglobin A, and you can see it's gone up dramatically in a short period of time from day 0. But you can see the first patients were at 3 months, and then they end up getting it to 15 months. And they looked at the number of, in the bottom is the number of vaso-occlusive crisis, the number of venous, vaso-occlusive crises that the sickle cell patients had. In the 2 years before treatment, they annualized, they averaged, 5, episodes, and a typical crisis ends somebody in the hospital from anywhere from 4 to 7 days. And then they showed that from the last visit, there were no events. Well, that was 2020. Well, they updated their data. Lovo-cel is, yeah. So Mark Walters updated the data with lentiglobin. And so this is using it to modify the beta globin gene and to turn it from hemoglobin S into hemoglobin A. And so to be eligible, they took sickle cell patients, and these are adult patients. These aren't children now. They're aged 12 to 50. They've had recurrent vaso-occlusive episodes. And so what they have now is 35 patients with a median follow-up of approaching 2 years. And so these are the data that was presented at ASH last year. And it was, by the way, the name Lovo-cel is I can't even say it. Lovo-tibiglogene autotemcel. I can't say it. Lovo-cel. But that's the official generic name. And you can see now there's far more patients, and we are seeing on average 50% of them are now having hemoglobin S. So when you do gene therapy, it's not 100%. You modify the product, you do the genetic event. A lot of times if we even do CAR T, we see that we got 40% transduction or 50% transduction. So, but to eliminate the sickle cell, you just have to get some hemoglobin A that will overcome the tendency to sickle. And so we now have stability months out after the infusion that patients are staying about 50-50. But importantly, if you look at the vaso-occlusive events, you could see the number of events in the 24 months before they were enrolled for the various patients, and then the various patients afterward. There was only one sickle cell event. And so now, we have that. That is a genetically modified corrected mutation. Well, now we also have exogamglogene autotemcel, which was also for severe sickle cell anemia, and this was also approved by the FDA. Now, this is sponsored by CRISPR Therapeutics and Vertex. It is not a lentivirus driven. It's a CRISPR edited gene. And what they're doing, instead of correcting the point mutation in hemoglobin A gene, what they're doing is affecting the promoter of the hemoglobin F gene. And so hemoglobin F usually is very high in the fetus, thus hemoglobin F. But then after birth, the hemoglobin F goes down and you start to make hemoglobin A. But you can actually turn on hemoglobin F with beta hydroxyurea. But by turning on hemoglobin F, you can accomplish the same thing as turning on hemoglobin A. So this is a non-viral cell therapy, and the goal is to turn on hemoglobin F and eliminate sickling. There's 42 patients, adult, age 21. 19 of 20 were at 1 year, had no veno-occlusive events. There were 30 patients evaluable at 9 months, and that one patient had one episode. 29 of 30 did not have episodes, and all the patients could be treated as in the outpatient setting. And again, very similar to what you saw for the lentiglobin, on the left here in the blue or purple are all the number of all the patients, the sickle events that had occurred that necessitated often hospitalization. And on the right, you could see the individual patients. And on the top was the veno-occlusive events that was experienced. And on the bottom is the hospitalizations required. Changing the natural history of the disease in parallel. And this was also shown at ASH, this past ASH 1053, so you can see they were right next to each other. But Franco Locatelli from Rome presented the data on thalassemia, also using the same CRISPR technology, and they could show that they could also overcome thalassemia and correct thalassemia, leading to transfusion independence in over 90% of patients, and also with marked improved quality of life. So we're now seeing genetic modifications and genetic therapy to correct two major hematology disorders. These are some slides that were collected, which says these are pros and cons of the different gene therapy. One is lentivirus, one is the CRISPR editing or base editing. This is for your resource. Now, why is this all relevant? Well, these were presented and FDA approved the day before the official ASH meeting started. Well, on the very last day of ASH, this is the late breaking abstracts. There's data that may have missed the original due date, but you have until like September 20th. If you've got really absolutely spectacular data that you want to get out there and share, you can be eligible for late breaking abstracts. So these are also very similar to like plenary presentations. And so the BMT CTN, that's our national clinical trial network, has run a study of haploidentical transplants in adults with severe sickle cell disease, same population what you just saw for gene therapy. This is a non-myeloablative platform. The other platforms are myeloablative busulfan. And so what we have is they do start with 2 months of hydroxyurea at 30 milligrams per kilogram. And then they, as a potentially to suppress sickling and stimulate hemoglobin F. And then they come in with the transplant platform of fludarabine, cyclophosphamide, thiatepa, and also thymoglobulin, high-dose thymoglobulin. And it's a donor marrow harvest. It's not peripheral blood. And they get post-transplant Cy and sirolimus. Sirolimus was chosen because many of the patients will have kidney disease as a consequence of long-term sickle cell. And so tacrolimus was felt to be a challenge to deliver that to a sickled patient. And so they're using sirolimus and post-transplant Cy with MMF. So again, the important thing to remember for those on the call, these patients do not need a graft versus malignancy effect. All we want is engraftment. Graft versus host disease is going to be morbidity and risk of mortality. So we can use a much more aggressive immune suppressive regimen. Let's achieve engraftment and let's see what happens. So again, they were aged 15 to 45. You had to be haploidentical first degree donor. So like in some ways, that grandchildren are now donating to grandparents. Well, that's a second degree donor. So it had to be brother or sister or mother to father, It had to be a first-degree relative. It was only bone marrow. Primary objective was event-free survival at 2 years. 54 patients were enrolled. 42 went on to allogeneic transplant. 12 fell off for different reasons. Median age was 23. The results were after transplant, there was only 3% episodes of veno-occlusive events, chest syndrome. I'm sorry, that should have been 30 something. That's my mistake. There was this should be 30 something percent vaso-occlusive events coming in. 17% have had chest syndrome and 17% had stroke. And the results show that the event-free survival at 2 years was 88%. 2-year overall survival was 95%. There were 3 graft failures that could be rescued. GVHD was 26% for grade 2 to 4, but only 5% grade 3 to 4. Severe chronic was only 7%. There was 3 deaths total in that first year, no deaths after year 1. One was organ failure with a patient who had ARDS, may have had infection simultaneous. A patient with CNS hemorrhage, which is known to happen to sickle cell patients, and then another patient with ARDS. So their conclusion is that haploidentical transplant using post-transplant Cytoxan can be suitable, can be curative, and can overcome, be used in patients with very severe end organ toxicity. And they want to point out that for most allo clinical trials, patients who've had stroke or have pulmonary hypertension and other pulmonary complications, they're excluded from myeloablative therapy or even the gene editing. They could not be managed on the gene therapy studies. So what they want to point out, and this is interesting, they compare gene therapy to haploidentical transplant. These are we know that transplant's curative. We don't know if gene therapy is going to be curative at 5 years or 10 years. It's non-myeloablative for haploidentical. It's myeloablative for gene therapy. It says eligibility are adults. The gene therapy have been young, typically was done in younger patients. As I said, it was also did take older patients. Haploidentical, we are able to find family donors pretty frequently. You do not, all you need is a living patient to do gene therapy. Stem cell procurement, bone marrow harvest. Some patients required multiple doses of plerixafor to get enough stem cells. Here you have to be FACT approved as accredited. Here you need to make the gene therapy product, you have to have a GMP facility. And they go on to point out there's chemotherapy toxicity with Cytoxan, but busulfan also has long-term toxicity with pulmonary fibrosis, SOS, and an increased and a risk of late effects of secondary malignancy. In the sickle cell population, post-puberty, fertility is a major issue. The gene therapy approaches pretty much assure infertility. The haploidentical reduced intensity actually would preserve fertility. And so basically their conclusion, which is that the final thing that we do to measure, so we see that haploidentical transplant seems to be safe. We're seeming to see the same efficacy as gene therapy, but they want to point out that the 2 gene therapies are now priced at $2.2 million for the hemoglobin F1 and $3.1 million, I believe, for the hemoglobin S gene repair. The cost of allo is typically about $300,000 American, maybe, for this type of approach. And so it's it's 90% cheaper. And so that should take it, of course, the person presenting the data felt that if he would have taken at the current status, they would recommend haploidentical transplant over the gene therapy. A little bit controversial, but it was a late-breaking abstract, but really important for the hematologists in America. And what about hematologists across the world? Well, there was also another presentation. This was on the plenary session. This was considered one of the top 8 abstracts of the 8,000 or so that were presented. And this was in sub-Saharan Africa, where there's no money, there's not anything. They've been able to get donations of hydroxyurea. They identified children aged 1 to 10. They all had sickle cell anemia. They had 635 patients. They treated them with a prodome of 15 to 20 milligrams a kilogram of hydroxyurea for 6 months. Then they escalated every 2 weeks to the maximum tolerated dose. And how did they determine that? Is when the platelets were under 100,000, if reticulocytes were under 1%, if hemoglobin was, fell below 5, if neutrophil count was above 3,000, that was when that was the MTD. So they established a optimal dose. They call it 27 to 29 milligram per kilogram. 606 started the hydroxyurea, 527 stayed on study. Duration of therapy was now almost 7 years on therapy with hydroxyurea in these children. They showed across the board that veno-occlusive events, acute chest syndrome, stroke, and splenic sequestration, and ultimately splenic infarction were all decreased. They conclude in populations where you have limited resources, aggressive hydroxyurea therapy can be safe and significantly beneficial. And what they've shown is the significant reduction in stroke and in death in mortality events. And they could show with the optimization dose, which ultimately they were able to get to, they had the lowest rate of death and significantly the lowest rate of stroke, which is associated with a lot of morbidity in this patient population. So that's my quick, maybe not so quick, summary of what I think are really important impact studies for hematologists. We don't usually talk about it, but this is cell therapy, this is transplantation, but this is also addressing issues of how we can improve delivery of care to the sickle cell patient in areas that are less financially solvent. What about transplant? Well, it turned out another top-rated abstract. This was the #1 abstract of all the abstracts. And Dan Wolf from Germany presented this. This was an analysis of the newest chronic GVHD therapy that's out there. So it turns out there's colony stimulating factor, CSF1 receptor, is found on monocytes and macrophages. And it turns out in chronic GVHD, we know that it's an inflammatory disease, and we know that we see the patients with sclerodermis changes, we see bronchiolitis, we see scar tissue. Well, it turns out that this compound, Syndex 6352 or axatilimab, is a high affinity anti-CSF1 receptor. It specifically targets monocytes and macrophages. So during the inflammatory event, if you generate CSF1, you're going to block stimulation of monocytes or macrophages. So this was a pivotal trial for registration, open label, phase 2. They had 3 doses. Now this was an interesting point. They were randomized 1 to 1 to 1, and at 3 different doses. The lowest dose turned out to be the winner. And so there's a lot of speculation of what happened is that maybe at the higher dose, you block the receptor for so long that the factor remains around and you lose the half-life of the drug. And there's so much CSF1 available that maybe you're later countering. But it does turn out that the lowest dose, 0.3 milligram per kilogram, was the winner. You could allow patients were chronic GVHD, they were advanced chronic GVHD, so they could be on they could be on active therapy, but the primary response was going to be overall response at 24 weeks. A cycle was 1 month. They used the NIH criteria, and so the results were that the overall response rate was 74%. That's the range at the 0.3 mg per kg dose. When you go to 1 mg per kg, it was 67%, and at the 3 mg per kg, which everyone thought would be the winner, it dropped to 50%. So the highest overall response and least toxicity was the 0.3 mg per kg. And so this is, I put in there for your benefit. Obviously we're not going to look at this all now, but if you want to look at it in detail, but I put the arrows, I added the arrows to show the key response rates, 74%, 67%, 50%. And importantly, the median duration of response, the durability of response, was 60% at 1 year, pretty much across the board. And so sustained response but once you had a response, you had a 50%, 50% chance it's going to be sustained. And of course, there are some treatment-related adverse events, but that always happens, but they're pretty minimal overall. So it was felt that this is a major breakthrough in chronic GVHD. So what do we have for chronic GVHD? In the last 5 years, we've had BTK inhibitors approved. So particularly for skin-only GVHD, ibrutinib works. We had ruxolitinib approved, which blocks the JAK-STAT pathway. We had the belumosudil, which blocks the is another one that blocks the fibrosis. That was approved a year ago, and now this is not yet approved, but everyone thinks that axatilimab will become yet another drug for chronic GVHD. Now, what was relevant, I thought, which was very interesting science, is there's a guy named Sar Gill from Penn. He's a member of the Carl June CAR T program, but Carl, that program at Penn has done so much in the field, and so but this is Patrick Mellers tackled this issue on bronchiolitis obliterans. Like what happened? So we know that the lungs become scarred. We know that you develop a very severe obstructive, but you can have restrictive lung disease, but you have a fibrotic obliteration of the small airways, and you lead to progressive respiratory failure. These patients sometimes have to go to lung transplant. But what they did is they identified patients who were having surgical resections or surgical biopsies who had bronchiolitis obliterans, or they obtained them at autopsy. But they obtained specimens also from control patients. And what they wanted to do is they say, what is different about bronchiolitis patients from, healthy, otherwise control patients? But what they did is instead of looking at macroscopic pathology, they looked at basically micromolecular biology. So they created single cell libraries from patients with bronchiolitis as well as, control patients. And they did then single cell transcriptomics. What was interesting is they could show that in stromal cells, so what's the target? We know the lymphocytes are going in. The lymphocyte populations are attacking. But it turned out the stromal cell backbone, the pericytes, the fibroblasts, that they are upregulating genes that are implicated in fibrosis and wound healing. They could show that like collagen and fibronectin was turned on. And they also realized the stromal cells are talking to CD45 positive cells, which is often where your lymphocyte population is, and that there's an interplay. And even in end stage bronchiolitis, there's still the crosstalk taking place between the the lymphoid the migrant cellular populations and the resident populations. And this is a quick little picture from the abstract. What you could say, this is a normal control. These are single cells. They can identify cell populations. These are monocytes. These are CD8 positive T cells. That's NK cells. But these are some of the stromal cells that you could normally see. And so what they can identify, this is the inflammatory market. And what they do is from bronchiolitis, you can see the populations are being enhanced. What's in circle are the stromal cell populations. And over here, they could just show you that these are genes implicated in fibrogenesis in normal controls versus positive versus patients with bronchiolitis. You're turning off some genes, but you're turning on a lot of genes that are associated with the inflammatory events and the stromal events. So bronchiolitis. So we now have two presentations, one getting to the pure molecular biology of why we're seeing fibrosis. And now we have new, therapeutics that's going to tackle those cells that are stimulating the crosstalk that leads to the fibrosis in bronchiolitis obliterans. Before I go on, any comments or questions so far? Or should I just keep going? I'll keep going. I don't see hands raised. Okay. Well, next one, a couple of them, these come together. We have our CIBMTR. Well, I also, we talked about it when I was over in Thailand. There's also the EBMT. Both of these are registries that collect data, and they collect data from participating institutions, and they pool that data. What can they teach us? And one of the first questions is, obviously the world is moving to post-transplant cyclophosphamide. You guys are using a lot of post-transplant cyclophosphamide as part of your GVHD prophylaxis. Well, where does it stand? We have big registries and big historical experiences. Where does post-transplant Cy? So in the EBMT, this is Olaf Pennick, another GVHD specialist from Germany, or maybe Switzerland. They're right next to each other. But they looked at the difference. They looked at now mismatched unrelated patients. These are mismatched at a single antigen. And they had 2,000 patients, 2,100 patients. Almost 600 patients got post-transplant Cy. The control group in Europe, in the United States, we do not use a lot of ATG. In Europe, they use a lot of ATG. So the control group, 1,500 patients or so with ATG. They showed that GVHD acute and chronic was really no different. And importantly, non-relapse mortality was certainly not higher. Overall survival trended to be, and was shown to be statistically higher. Progression-free survival higher. So here, with going against 20 years history of ATG-based chronic, mismatched unrelated, post-transplant Cy has a higher overall survival. Well, that's mismatched unrelated. Well, they also simultaneously looked at matched unrelated. A bigger product. We use more matched unrelateds. Now we're getting close to 9,000 patients, and they have almost 8,000 with ATG and 1,000 patients with post-transplant Cy. What they showed is post-transplant Cy, that chronic GVHD had lower rates. There was no difference in acute GVHD. They did not see any statistically significant difference in the relapse rate, but overall survival and progression-free survival, which is basically a measure probably of chronic GVHD, is actually improved. So 2 big retrospective studies talking about a change of therapy, and this is now moving into myeloablative transplant. You can see that 50% of the patients were myeloablative. I previously shared the data from the United States study of reduced intensity, where reduced intensity showed in a prospective study that post-transplant Cytoxan as a graft versus host disease prophylaxis was superior to tacrolimus and methotrexate. Now we're seeing it extending in really big numbers into the myeloablative world. The big question then is that we asked the question about relapse. This is another study from the EBMT. Arno Nagler from Tel Aviv presented this, and they looked at standard of care versus tac methotrexate. So they looked at standard of care was either tac methotrexate ATG or cyclosporin MMF versus post-transplant Cy. Post-transplant Cy is in the yellow. And what they basically, the important thing is this slide here, relapse. There was no increased relapse with post-transplant Cy. So we're saying that post-transplant Cy seems to be safe, actually seems to be providing a important clinical signal in some settings. And like we saw some data saying we have better overall survival. And now we're looking at Griffiths, and there's a slight trend to better Griffiths, GVHD, relapse-free survival. So that's my quick little snapshots of a couple of highlights on, so you saw highlights on hematology and highlights on transplant. I was going to finish the next 10 or so minutes, 12 minutes with highlights on immune effector cell therapy. And whatever I don't finish at 6:50, I'll just save it for the future. This was really exciting to me. This is more biology. So we know across the board, CAR T has been very successful for lymphoid diseases. We're doing it, you're doing it. Everybody's really, the world's explored. They announced somewhere in the meeting, over 35,000 patients have now been treated with CAR T for lymphoid malignancies since 2018. So it's now a standard of care. Over and over, people have tried to develop CAR T for AML, and most of them have failed. And you look at what's failure, it's like the leukemia blows through the CAR T, or all you use the CAR T for relapse refractory is a bridge to allo transplant. But even then, you don't get a deep enough response, and the allo transplant fails. So this is again from I mentioned Gill did the bronchiolitis single cell transcriptomics. This is another study from Gill's lab. And so what they did is they generated CD123 directed CAR Ts. They're going to look at relapse refractory AML. They signed up 20 patients and started to generate autologous CARs. Only 12 were infused. 8 of them died, probably of progressive leukemia, and never had a chance to get to CAR. But so what happened to those 12 patients? Well, 8 of them, so they used the standard lymphodepleting chemotherapy with cyclophosphamide and fludarabine. They got 4 patients with complete remissions with incomplete hematopoietic recovery, 3 progressive disease, 5 stable. So the leukemia is still there. You haven't got rid of it. So you spent a lot of time and effort, but you still have disease. 2 patients died of CRS who have a non-relapse mortality. And what happens is leukemia, we've seen this in ALL. If you have high blast percent in the marrow, if you have high blast percent in the peripheral blood, your risk of life-threatening CRS is markedly increased. So they have 4 remissions, and out of this 20 that started this trial, only 2 are alive long-term, and only 1's alive with CARs only. The other patient was rescued, was taken to allo transplant. Now, in that setting, 10 patients, though, had clinically significant CRS. So they asked the question, sometimes when we see high CRS, that usually equates to a high peak expansion of the CAR T, so we expect better outcomes from the CAR. But we're having low responses. So what's going on? So they also did a cellular and molecular analysis. They used RNA-seq analysis, and they grabbed they took the AML blasts, and what they showed, they took them out of the patients, and they also used serum. They used they exposed them to cytokines that you see with cytokine release syndrome, interferon gamma. They saw IL-6, and what they showed is when leukemic blasts, when myeloid blasts see the inflammatory cytokines associated with CRS, the blasts will upregulate a survival pathways. And it appears to be through JAK-STAT. They looked at GM-CSF. We know that AML blasts have GM-CSF and G-CSF receptors, and we know that GM-CSF is stimulated by macrophage and monocytes, and we know that macrophage and monocytes are absolutely critical to CRS. Well, so let's look at GM-CSF, and they exposed the blast to GM-CSF, and what they showed is that blasts exposed to GM-CSF became less likely to be killed by CAR. And then what they showed is if the blasts don't die, the CARs are still trying to kill them. And then what you do is you get much faster onset of T cell exhaustion. And so you get T cell energy. And then basically the blasts don't die. So then they went back and said, well, this is all JAK-STAT. Are there any easy ways to block JAK-STAT pathway? Well, we all know that ruxolitinib blocks JAK1, JAK2. And so they basically treated the blasts and they reintroduced to these refractory blasts, they treated them with ruxolitinib, blocked the signaling, and what they then did is reintroduce the ability for the cells to be killed. So it isn't really understand why, but clearly myeloid blasts do have a different biology than lymphoid blasts, and that for us to develop successful immune effector cell therapy for treating AML, we have to understand that biology. Important, I think. This is maybe less important, but everything's important. Tisagenlecleucel is the first drug that's approved for follicular lymphoma. This is the one that was approved for large cell lymphoma. This is Tisacel. So the ALARA study is the phase 2 study that led to the FDA approval. Well, now we have 3-year follow-up, and these are the curves for progression-free survival. And these are all patients with follicular lymphoma that are POD 24s. These are progression of disease within the first 24 months. So these are the bad actors. And what we know is we saw now with 3 years out, we're seeing a median progression-free survival of 40% approximately. But if you got to CR, and CR was seen in 70% of the patients, 70% remain with progression-free. Those are your safety signals. Pneumonia, 11%. CRS was 20%. But overall survival was 80% at 3 years. So that's really good for this population. So what is POD 24? This got blended. What I was just trying to point out, this is a schema for those of you who are just need to be reminded. You see follicular lymphoma, a lot of follicular lymphoma you could just watch. If it has histologic transformation of large cell, you got to treat it. But along the way, most people, when they officially progress, you're treated with a therapy like bendamustine rituximab or R-CHOP. And if they relapse if they progress early, you want to take them to transplant if you can. And if they, but sooner or later, they're now candidates downstream for CAR T therapy. Along the way, this is my slide just got too jammed up. But either way, it's just reminding us that progression inside of 24 months is bad disease. These are the data of auto transplants. I'll have to fix this slide. And this is the data of allo transplants. What we basically have is if you either have auto transplants or allo transplants, this has been our historical best therapy for POD 24 follicular. That's 70% for CR and 80% 3-year survival. If you look, here's our 3-year survival. It's about 70%. Here's our 3-year survival is about 70%. That CAR T should be considered as a treatment option for quality of life. It does appear to have equivalent 3-year outcomes as follicular of either treated with auto or allo. Oh, well, we'll skip that. You can look at that. Oh, I know what it is. Sorry. This was supposed to be deleted. And I guess it didn't get deleted. Never mind. If you, I'll fix it. This here and this here, this was just going to be the algorithm, and this slide was these pieces. I just did this all the last couple of days, so forgive me. What about brexpiprazine in also updates? This is just real world. We now, the brexpiprazine is FDA approved and EMA approved for adults with refractory ALL. What about real world? Well, there's now 190 patients, 19% with active CNS disease at the time of CAR. And this is the table that they present. The key is, if you go down, is the overall survival. The median is 16 months and 6 months of 81%. These are the curves. We all know with relapsed refractory ALL in patients who've had prior blinatumomab was in 56% of patients, prior inotuzumab in 50%, and prior allo transplant in 40%, and other CARs in 2%. These are patients that we expect poor outcome, and what we now see is we're getting survival. So again, CAR T is now becoming a standard of care. And then what's nice about real world data is it's often more ethnically diverse, and it's also less selected for organ, it's less biased and less organ selection. In the same way that brexpiprazine in the real world for ALL, well, we now have brexpiprazine in the real world for relapsed refractory mantle cell. This is a German-Swiss combined analysis, 111 patients. And again, these are patients, 1/3 of the patients had blastoid variant, high risk disease and intermediate risk in 70% of patients, P53 disease in 20% of patients, and the median number of prior treatments were 3. Over half the patients had prior auto transplants. And what you can see is the projected overall survival was median of 2 years, and there's an 86% response rate. It appears to be relatively safe. There is a high grade with mantle cell. There is a higher grade CRS, ICANS also higher grade, but that's often because when a lot of these patients have mantle cell leukemia along with their mantle cell lymphoma. Importantly, only 9% death within the first month, but this is how they died of non-relapse mortality of the 20% overall, 11 infection, car related, but 5 were unknown. Lysocabtagene, well, this is my consortium, and so we just presented, and I'm just going to go right to it. So lysocabtagene is also being looked at. This is now large cell lymphoma. This is the one that's considered to be the CAR T for old people. It has lower rates of risk. And these are our patients. I'm going to leave these slides for you to look at them. Patient characteristics. Importantly, we are seeing good, strong duration of response of the median follow-up at 12 months. And our overall survival, it's still short follow-up at 6 months or so, 7 months overall survival, but we've got over 50% overall survival. So Lysocell is another good drug for us. And this is the conclusions of our that we think it's an effective agent. I got 2 minutes to finish. I will just tell you this is an abstract. So what do right now we have two CAR Ts for myeloma. We have idacaptagene and we have ciltacabtagene. They both see BCMA. Well, guess what? There's another CAR T coming, and there's another target antigen on myeloma called the G protein coupled receptor class group 5 or GPRC5D. This is a study of patients sponsored by Bristol Myers Squibb, 70 patients. 46% had prior BCMA, including prior CAR T, and they're now showing overall response rate of almost 90% and 75% in BCMA. So right now we have bispecific antibodies that see BCMA, bispecific antibodies that see GPRC 5D. Now we are going to have 2 CARs, and that's the response data. I think my final slide is I'll say wait for the big. This is the big talk of the town. This is autoimmune disease. Only 15 patients, but this is autoimmune disease, single center experience. 8 with lupus, 4 with scleroderma, 3 with myositis. 15 out of 15 had autoantibodies active at the time of CAR T. You had to have at least 2 organ involvement, and what we saw is that in the lupus patients, you had complete remission at 3 months with no ongoing lupus activity. 3 of 3 myositis patients with major improvement and normalization of creatine kinase. The scleroderma patients, 3 of 4 patients had symptomatic improvement. All 15 patients came off all immune suppressive agents. And what we're seeing is healthy B cell recovery is being seen. And with healthy B cell recovery, we're not seeing relapse of the autoimmune disease. The world is abuzz of that CAR T next is going to take on rheumatology diseases. I'll skip this, and I finished. And this is, by the way, this morning, I got in here early. This is, again, I like to show the picture. That's the mountain from my office. But with this time we have dawn, but this is the big fog over the river. And so we, out of nowhere, those of you that have ridden the tram, well, it looks like the tram is just sitting in the middle of nowhere because it disappears here. So I stop here, and like usual, I talk a lot. I can always fill the hour with my conversation. I don't know how it's received, but it's here for you. I just provide the information and whatever I can do for you. I hope this is useful, and I'm here for questions if you want.
Thank you, Prof. Dr. Surapon, please.
Thank you very much, Richard. It's very informative. I think there are several interesting topics. I would like to ask you about the post-transplant cyclophosphamide USD prophylaxis. In unrelated match unrelated donors,
Yep.
transplant and reported by EBMT, they use only post-transplant cyclophosphamide, no other reagent, other agent, right?
Oh, no, I'm sorry. They also had some support. I sort of simplified it. They do have some support agents with it. It wasn't just Cytoxan,
Not only just
not only
cytoxan, huh?
Cytoxan, but it was like cyclosporin MMF, but it was not using ATG or the others. But the
Okay.
highlight is it was short course treatment, and that they're just saying that we're replacing the PT-Cy.
Okay. Okay. Short course
When I
meaning
send you the slides, I'll make sure I put the full regimen there.
okay, good. Thank you. Thank you.
Good pickup. And
Yeah.
I know, with Wanapa on the phone, she's got to like be excited about, as a physiatrist, she's got to be excited that scleroderma can now be treated with
That
with
is
CAR T.
that is excellent because I have seen the scleroderma patient also so sad for their life, very thick skin, very hard to move, joint contracture and everything. So thank you, Prof, for making the beneficial update to all of us. We have Dr. Nutra here as well from the Smith side. You have any question for Prof?
No, but I think your lecture is very, very good. Thank you so much.
Well, อาจารย์คะ you might miss the earlier part of the video call on January 24th his time, 25th our time. We would like you guys to present what's learned from OHSU and what you can do to Smith Children's Hospital นะคะ We will send the email later today.
ค่ะ
Thank you
ค่ะ
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 Okay, thank you very much, Richard. I wish you all the best from Christmas and New Year. Thank you.
Thank you. And I will say that I will look forward to Dr. Nutra being part of the conversation and leading the discussion next time.
Okay, good.
Everybody, great to see you, Richard.
Thank you
Okay, Happy
Thank
New
you.
Year.
Bye-bye.
Thank you ค่ะอาจารย์
Great.
Prof.
Happy
Surapong.
holidays.
Everybody, this is honestly